Lo que necesitan saber y más. Necesitamos. ¿Se escuchan ahí?
Welcome, everyone. Thank you for joining us for this session of heart failure with preserved EF, everything you need to know and more. My name is Anita Radhakrishnan, and I'll be chairing this session. I'm an echocardiographer, and I practice advanced cardiac imaging at Allegheny General in Pittsburgh. I would like to take this opportunity to thank American Society of Echo for giving me this opportunity today. So we all know that we can use echo to better understand the hemodynamics and physiology in patients with heart failure with preserved LV function. And in return, we can provide better patient care for them. The overall principles in diastology has not changed, but grading diastolic function continues to be a challenging and controversial area in echocardiography. We hope to use this session to take you through the ventricular physiology, the hemodynamics, the grading of diastology and possible future changes, and a case-based discussion with common dilemmas we experience on a day-to-day basis. We have expert speakers in this field, and we hope to use this session to affect your daily practice. Next slide. So you can submit questions in the Q&A box. The questions will be monitored throughout the session, and he's one of our authors for the ASC document.
And more. We're going to talk about ventricular and vascular physiology and hemodynamics, and hopefully in about 15 minutes.
Pero, ¿están escuchando o no escuchan?
Sí, doctor, ¿escucha bien?
Sí, escucho bien.
¿Sí escuchan bien? Ok.
Sí.
Sale, ahí va de nuevo. Ahí va, digo, con este doctor Aurillo.
I obviously won't be able to cover this in incredible detail, but I'd like to highlight some of the interesting research that's been going on in this field. A lot has changed in the last few years about how we think about it, about the topic of HFpEF, which is ubiquitous. So let's start with a little bit of physiology. We know that as opposed to systole and diastole being two separate entities, they're really one combined activity of the heart. The heart generates stroke volume in systole and fills for the next cycle in diastole. We know that normal diastolic function includes the ability to fill at adequate end diastolic volume at low pressure. And it does this in part because of the descent of the base toward the apex. That generates a suction effect, and because of twisting of the ventricle in systole and the parallel untwisting of the ventricle in diastole, and both the recoil from the descent of the base and the untwisting of the ventricle helps to suck blood in to the heart at low pressure. So if normal diastolic function features the ability to fill at normal pressure, as Bill Gash says, that diastolic dysfunction is an inability to fill at normal pressure. And that occurs either because the ventricle relaxes slowly, you see on this dotted line, compared to the normal rapid decay in pressure at the end of systole. Ventricle with diastolic dysfunction may have abnormalities in relaxation and may also have abnormalities in its intrinsic stiffness, so that the pressure-volume relationship is shifted upward and leftward. What does that mean? It means that at any given volume, the heart with diastolic dysfunction, shown in the dotted line, has a higher diastolic pressure. It also means that as you fill the ventricle, the pressure rises much more quickly than it does in the normal heart. So by and large, most people with diastolic dysfunction have abnormalities in relaxation. Relatively fewer have abnormalities in passive stiffness of the ventricle. You can certainly have both. When you have an inability to fill at normal pressure, which is severe enough that you have pulmonary edema, you have heart failure, not just diastolic dysfunction. There are lots of people walking around with diastolic dysfunction who don't get into any kinds of trouble with pulmonary edema. Perhaps if their heart rate goes up a lot or if their pressure goes up a lot, they can develop abnormalities in filling and pulmonary congestion. But by and large, they do well without heart failure. When you have the syndrome of heart failure and you have diastolic dysfunction, you have heart failure with preserved ejection fraction if your EF is normal. So the consequences of diastolic dysfunction, as I've suggested, high filling pressures mean high pulmonary venous pressures. The LV filling pressures are high. This can get back transmitted to the lungs. Stiff left ventricle means volume sensitivity, means a small amount of volume will drive the pressure up quickly. And as I think most of us have found out, if you overdo it with diuretics, you can have a patient go from pulmonary edema to steep Trendelenburg at a low arterial pressure very quickly. The impaired ability to relax means exercise intolerance, because if you increase the heart rate, you really diminish the ability of the heart to fill at normal pressure. I'm going to skip over this last point. We'll get to this in a little bit. Some very important work on this was done many years ago by Delaine Kitzman from Wake Forest, who at that time studied a bunch of patients, actually a relatively small number of patients with diastolic heart failure who were admitted to the hospital. And Dr. Kitzman, in an elegant tour de force piece of clinical research, exercised these people and exercise controls with a Swan-Ganz catheter in place. And what he found was that there was a double whammy in patients with diastolic heart failure. When they exercised, their pulmonary capillary wedge pressure went up significantly, these open circles, compared to normals. And when they exercised, their stroke volume response was flat compared to normal people. So normal people, when they exercise, are able to augment stroke volume, at least early in the exercise, without an increase in pulmonary capillary wedge pressure. Diastolic heart failure patients are unable to do that. So they suffer an inability to augment their cardiac output, but at the same time, their filling pressures go up dramatically. Diastolic dysfunction is the tip of the iceberg. When you see it in HFpEF or even asymptomatic patients, we're only seeing one small portion of the universe of people with diastolic dysfunction. Diastolic dysfunction is present in virtually any disease that presents with pulmonary congestion or right-sided congestion. So many years ago, when I first started speaking about this topic, I used to say these were the faces of diastolic dysfunction or diastolic heart failure. We called it diastolic heart failure then. The older woman with hypertension who goes into pulmonary edema after Easter dinner. We had less appreciation of this particular face, but when the CHARM study came out, we began to recognize that there were other types of people with diastolic heart failure. This individual has a mixed picture of coronary disease, hypertension, diabetes, AFib, obesity, and then finally, the patient with restrictive cardiomyopathy. We're not going to spend a lot of time talking about restrictive cardiomyopathy. We don't call these faces anymore. We call them phenotypes. And that makes us feel much more scientific if we use the term phenotype. To take the third phenotype first, the restrictive cardiomyopathy, I think the last few years has witnessed an explosion in the diagnosis of amyloidosis, mostly TTR amyloid, transthyretin amyloid. And I think strain imaging, if you had to pick one application for strain imaging that makes it useful in 2020, it would be the diagnosis of cardiac amyloidosis. Even in patients who have aortic stenosis, who don't really get better after they get a TAVR, or this comes up in the course of their TAVR evaluation. So hopefully the phenotype approach, recognizing different subtypes of heart failure with preserved ejection fraction, will enable us to treat people with a little bit more personalized fashion. And we're going to talk about the two major phenotypes in a second. Let's start with this guy. Again, diabetes, obesity, perhaps coronary disease, perhaps atrial fibrillation. So I kind of gave away the answer, but what percentage of HFpEF patients are obese? These are people enrolled in clinical trials of HFpEF. The answer, I was surprised when I found this out, is 80%. And here's an echo from somebody with heart failure with preserved ejection fraction. Notice the image quality is not exactly restaurant quality because of the obesity. Multiple layers of pericardial and epicardial and pericardial fat that we see very commonly. We know now that the visceral fat is probably a lot more toxic than the fat that is outside of the pericardium. That's a whole separate lecture. And one thing I'd call your attention to is this flattened septum. We're going to get to that in a second. We wrote an a review of cardiac remodeling and obesity a few years ago, Tim Fitzgibbons and I. And one thing we found out, was much to my surprise, was that the prevailing type of remodeling in obesity, now these weren't HFpEF patients, this was obesity, was concentric remodeling, concentric hypertrophy, meaning thick-walled ventricle. We also found that there were a variety of subtle abnormalities that one could observe. We're going to get to that in a second. I recommend, if you read no other papers I'm recommending in this talk, that you take a look at these two papers by Obokata and the accompanying editorial by Delane Kitzman and Carolyn Lamb, who are both experts in this field, talking about the obese phenotype of heart failure with preserved ejection fraction. It turns out there is a whole subfamily of abnormality that occurs among these patients. In addition to diastolic dysfunction that we can measure with transmitral and tissue Doppler, there's pulmonary hypertension, which leads to RV remodeling, abnormalities in left atrial strain, which we'll get to in a second, enhanced ventricular interaction, vascular stiffening, and even chronotropic incompetence. And to kind of recapitulate the Kitzman study, Obokata and co-workers from the Mayo Clinic showed that obese patients who had an inability to augment, who had a relatively low V.O2 max, were really unable to augment their cardiac output with exercise, just like what was shown 20 years prior by Delane Kitzman. And that any augmentation of cardiac output came with an unwanted increase in pulmonary capillary wedge pressure, just like what was shown in heart failure with preserved ejection fraction. As they exercised, they developed more septal flattening, likely reflective of pulmonary hypertension. Now, we're spending a lot of time these days thinking about atrial fibrillation, not only in HFpEF patients, but just in general. What people have called attention to recently was the interaction between AFib and HFpEF. And there's a lot of exciting work on this topic. And I think it's useful to understand exactly how incredibly elegant the atrial kick mechanism is. The atrial kick mechanism is really designed to allow the ventricle to spend as little time in elevated diastolic pressures. If we have diastolic pressure on the y-axis and volume on the x-axis, relatively little time spent at a high diastolic pressure just with the atrial kick. However, when a heart that has abnormal diastolic properties to begin with loses the atrial kick, what happens? Well, if normal mean diastolic pressure or diastolic pressure in the left ventricle is 8, HFpEF in normal sinus rhythm will say is 10 if they're in sinus rhythm and they're not in heart failure. When they lose their atrial kick, to get the same degree of fiber stretch that the atrial kick provides, you have to spend a lot more time at a high diastolic pressure. So if you want to get to optimum fiber stretch without an atrial kick, you have to spend all of this time here in early to mid diastole at a high filling pressure. Or conversely, give diuretics to keep the volume down, therefore to keep the pressure down, then may have a relatively low stroke volume heart. Forgive this little technical glitch here for a second. Let me go back. Okay, let's go back to this. So again, people have been calling attention to the interaction between diastolic dysfunction and atrial fibrillation. It is perhaps the case that chronic increase in left atrial pressure leads to LA dilation, left atrial dilation, LA stretch, fibrosis, especially if you dial in some obesity with inflammatory cytokines on the back wall of the left atrium, probably leading to left atrial fibrosis and atrial fibrillation. So there can be a vicious cycle where there's interaction between HFpEF, left atrial dilation, throw in some obesity, atrial fibrillation, which, as we've seen in the prior slide, makes the whole issue of increased left atrial pressure worse and perpetuates the cycle. There's a lot of exciting research on left atrial strain. Left atrial strain we generally measure when the left atrium is expanding during its reservoir phase. The left atrium expands when the ventricle is contracting as it's filling up with blood before the mitral valve opens. And some really interesting work has shown that abnormalities in left atrial strain really are associated with worse clinical outcome. And a really fascinating paper by Thomas and co-workers, this is Liza Thomas, not Jim Thomas, shows that perhaps the first thing to go in progressive diastolic dysfunction is the left atrial strain, which can become abnormal before the left atrium enlarges, before the E to A ratio starts dipping, before the E to E prime ratio, either at rest or with exercise, becomes abnormal. So I call your attention to this phenotype-specific approach to HFpEF. Let's go back to the first of the phenotypes, the one that I think when you think about diastolic dysfunction, diastolic heart failure, you think about someone like this, who's got longstanding hypertension and goes into heart failure with overindulgence in salty foods or discontinuation of antihypertensive medications. Here's a typical ventricle of such a person, thick-walled ventricle, good contraction. Systole is certainly not the problem, and this person is in pulmonary edema, as the diastolic profile shows. Now, the concepts involved here are a little bit more advanced, and I'm going to oversimplify them for the audience, because they really require a careful study. But I'm just trying to paint this in very broad outlines. We know that the arterial system in certain HFpEF patients is abnormal. What does that mean? It means for any given increment in volume, the pressure in the arterial system goes up. That's what stiffness means. And in general, the stiffness in the arterial system and in the ventricular system are increased to roughly the same degree. And let me just illustrate this with some pressure-volume relationships. So here's the pressure-volume loop. Ventricle fills, isovolumic contraction, aortic valve opens, ejection, relaxation. This curve describes the pressure-volume relationship in the ventricle and diastole, and this is the line that represents the contractility of the left ventricle. So the heart generally moves along a given contractility line. We'll see what that means in a second. And the arterial system has a certain stiffness as well. And the slope of these lines is roughly the same. That's known as ventricular arterial coupling. Again, I'm oversimplifying. Now, if you take a normal ventricle at a given arterial stiffness and you increase its volume by, let's say, volume infusion, blood transfusion, bag of potato chips that's ingested, the ventricle shifts to a larger end diastolic volume and a somewhat higher end diastolic pressure. And when it augments its pressure with isovolumic contraction and then ejection, it contracts down, but it ends up at a higher arterial pressure. And that is solely the result of the increase in volume. On the same pressure-volume relationship in diastole, you end up at a higher end systolic pressure as long as you're on the same line of contractility. Now, what happens is if your arterial system is now stiffer to meet stiffer, what one sees is that volume loading increases the end systolic pressure as well as the end diastolic pressure. And this type of parallel increase in arterial stiffness and ventricular stiffness has been described among patients like the one I showed you. So if you take the control, ventricular stiffness and arterial stiffness, these slopes of these two relationships are similar. What has been observed in some elegant research by David Cass's group is that the ventricular and arterial stiffness are both elevated, but the ventricular stiffness is elevated out of proportion to the arterial stiffness. And what this translates into is that as you raise the ventricular pressure or you volume load the left ventricle, you can have a significant increase in end systolic pressure. And this was described by Bill Little many years ago, the late Dr. Bill Little, who's made some incredible contributions to our understanding of diastolic heart failure. He explained flash pulmonary edema as such. You had a trigger. The trigger might have been an increase in arterial pressure, or it might have been an increase in volume. Ventricle and arterial system being stiff because of activation of the sympathetic and renin-angiotensin systems, you have arterial and venoconstriction. So if you infuse volume or the blood pressure rises, these lead to an increase in blood pressure, and because of the increase in venous tone, blood is redistributed back to the thorax. The right ventricular stroke volume increases because of the increase in volume being redistributed. However, because the left ventricle is stiff, transiently, that blood cannot be pumped out quite as much by the left side, because even though the volume in the left ventricle has gone up, if the chamber is very stiff, the left ventricular stroke volume is not going to increase very much. So what this means is that the blood backs up in the left atrium, causes an increase in left atrial pressure, pulmonary congestion, poorer oxygenation, perhaps ischemia, and so this trigger can be amplified dramatically and result in flash pulmonary edema. So, to summarize, 3 principal phases of HFpEF. What can we do? I'd like to leave you with an optimistic note. Well, if I had one, given that we don't have specific treatment for HFpEF at the moment, treat the blood pressure. And if you have atrial fibrillation, try to get those people back into normal sinus rhythm. We have improved treatments for atrial fibrillation, but treat the blood pressure, treat ischemia, and perhaps avail yourself of monitoring devices, because when things go bad, they can go bad pretty quickly. We know this from these implanted pulmonary artery diastolic monitors, showing that people can kind of poke along and then have a slowly increase in their diastolic pressure in the pulmonary artery, and then they get a period of time where their probably lymphatic system is overwhelmed and they go into pulmonary edema, and then they get treated. So we have better monitoring. We have the time-honored measure of treating blood pressure. I think we're going to be more aggressive with treating atrial fibrillation until we wait until a specific therapy for HFpEF comes along. So with that, I'll quit, and thank you for your attention.
I would like to thank Dr. Arjima for an excellent presentation. That was a nice review of the underlying physiology and the hemodynamics and how we can use that on a day-to-day basis when we're assessing echo guidance for diastolic function. Introduce Dr. Otto Smith-Seth, who needs no introduction. He's a professor and the director of cardiovascular group at Oslo University, Norway. He's heavily published and has more than 300 PubMed articles, including 26 in Circulation, 21 in JACC, and 16 in European Heart Journal. His major interests include cardiac imaging and pathophysiology, diastolic function, and LV dysynchrony. He'll be presenting myocardial relaxation and stiffness in the era of mechanics. Dr. Smith-Seth.
I'm also grateful to the American Society of Echo for inviting me to give this lecture on this very exciting session. HFpEF is, as you know, one of the major health challenges. Now, the relaxation and stiffness issue. Next slide, please. This slide shows the different phenotypes of HFpEF, and even more. The most common one is arterial hypertension, very often combined with CAD. And then you have the more specific phenotypes, which are listed on this graphics here. And importantly, please note that aortic stenosis and the TAVR, or the post-TAVR, is now a major challenge for diastolic function as one of the determinants of the outcome after the TAVR. We know that hypertension gives hypertrophy, and it also gives fibrosis, which makes every element of the myocardium stiffer. So it's not only thicker, but the myocardial elements are also stiffer. And in this nice slide from Weber and Briella, they show the interstitial fibrosis, which is sort of a major pathogenetic factor in HFpEF in hypertension. Now, aging is an issue, and as some of you know, people who are old tend to get smaller hearts and stiffer hearts. This is from the MESA. It's an MRI CM heart study of healthy people, showing that with age in the lower left panel, volume gets smaller in men and women. In the upper right panel, the mass per volume is bigger, so it's a stiffer ventricle with aging. Now, just to move quickly to this very nice study, which shows that the wedge pressure versus end-diastolic volume, which actually is a measure of compliance in the ventricle in healthy people, to the right in the young, to the left in the old. And when the people get old, they need a higher pressure, a higher wedge pressure, PCW pressure, to distend the ventricle to the same volume as in a younger person. So aging gives stiffness. Good news is by physical exercise, you may sort of reduce this stiffening with aging. Now, a very nice study by Dr. Origema some years ago. He could show that in patients with HFpEF, he called them at that time diastolic heart failure, but HFpEF, and to the right you see HFrEF, and you see in the middle normals. And the point of the slide is that with HFpEF, LV pressure is much higher for any given volume. That is stiffening. That is sort of the hallmark of HFpEF. We would like to, if feasible, to measure the pressure volume curve in the clinical routine, but it's not possible, unfortunately, because we don't have the invasive pressure. That's why we have to rely upon echo and echo indices and indirect markers of a stiff ventricle. And we have a number of very nice tools, so it's feasible to get a good impression of stiffness in the regular echo in a standard sort of manner. Now, there are some advanced technologies to measure the structure of the myocardium. The stiffness by ultrasound, shear wave imaging, it's in development and promising, but yet not ready for clinical application to get the structure by echo. Even CMR is challenging, gives you information, but doesn't really give what you need all the time, and it's not yet implemented clinically, but promising. Now, to a very important issue, as many of you know, TAVR, treatment of aortic stenosis, which is a very common disorder, by the transarterial valve implantation, the TAVR, is a very important and a very good therapy. We also know that patients with TAVR, who get the TAVR, and get the reduction in the aortic stenosis or abolish the aortic stenosis, most of the patients do well. Some have trouble. I've seen patients who get a very successful TAVR, but still having shortness of breath, heart failure with a normal ejection fraction. The reason why is that the aortic stenosis patients with the hypertrophied ventricle, with the fibrosis in the myocardium, they are not cured just in a few weeks. This is a study some years ago done by a Swiss group, Otto Hess, and it shows nicely to the left, you see just schematically a TAVR, and you see a little bit surprising. I'll take you slowly through the slide, which contains very important information. On the y-axis, you see the stress. Could have been the pressure, but they measured stress. On the x-axis, you see the strain. And now let's focus on the black circles. On the crosses. The crosses are the controls. They had some healthy people, or apparently healthy, went to the cath lab to rule out disease. And you see the pressure volume curve or the stress strain curve of the healthy, that's the crosses. Then you see the patients with the pre-aortic stenosis surgery, pre-SAVR. You see the black closed dots, that's the pre-surgery. And very surprisingly to some, you see that the early period after the aortic valve surgery, and I guess it's the same with TAVR, you see the first almost 2 years, it's a stiffening. So the open circles is the stiff ventricle the first 1 to 2 years after the aortic valve surgery. And it takes almost 5-6 years to get the normal compliance again. That is the squares at the right there. And it was supposed that the reason why you get the stiffening of the ventricle after aortic valve surgery is that the myocytes, they regress relatively soon, but the fibrosis stays around for a long time. That might be one factor, and one reason maybe why the diastolic stiffness is a major issue in patients who are undergoing TAVR. Now, when we are doing echo to image stiffness, it's challenging, but we have some good tools. I have just schematically here shown you the LV pressure and the left atrial pressure in one case. And you see to the left, I have shown the early diastolic mechanism of stiffening, that's relaxation slowing. And with the E prime, which reflects the relaxation, you get a good sort of impression if it's a normal or if it's a slow relaxation. In some patients, the green area would cover most of the diastole, but normally relaxation is finished in early phase. The little bit reddish area is the passive elastic period of stiffness, which is when the ventricle is relaxed more or less completely. And the lower right panel shows you the E deceleration time, which is a good index to reflect the passive elastic stiffness. It's not perfect, but relatively good. Now, the next slide shows you another very useful measure, which I do myself. Every time I do an echo, I try to get it good in maybe half of the patients. I measure the duration difference of the mitral A and the retrograde pulmonary venous A. And if the difference is big, if the retrograde A is much longer duration than the antegrade A, it's a marker of a high late diastolic pressure or a stiff ventricle. Nice work from Chris Appleton, who shows here in the patient that the upper panel shows to the left the mitral A, and to the right the pulmonary venous A, almost the same, 125, 120 milliseconds. In the lower panels, you see the duration is much longer. For the reversed A, it's a high LV EDP, and probably a stiff ventricle. Useful tool. For stiffness, we know that patients who have pulmonary congestion, they have high LV filling pressure. And that is an indirect reflector of stiffness, because the high filling pressure most of the time is due to a stiff ventricle. You can get flush pulmonary edema, like in this paper by Bill Little and co-workers some time ago. You can get flush pulmonary edema if you have a very stiff ventricle, like in hypertension here, which was a dramatic case, but it happens sometimes. Now, for the daily routine, you can do a lot to estimate filling pressure. This is from a paper Dr. Nagy and I did some years ago, well, not that long ago, Sheriff, 3 years ago, and we could show the utility of applying the very simple tools, tricuspid regurg velocity, mitral angular velocity, and the mitral flow velocity, and the LF volume. And then we could, in most of the patients, we could assess filling pressure nicely. Have a look at the guidelines from first authored by Dr. Nagy, 2016, and this paper confirmed the guidelines for doing fine. Now, do we have any extra help? Sometimes in the echo lab, you're doing all this stuff, you get the mitral EA, and you get the E over your prime, and you get the LF volume. But sometimes you don't have the tricuspid regurg velocity. You are stuck a little bit here because you don't have all these variables. Any help to get? Yes. I did a study now with Sheriff and a number of other centers. We could show that LS strain is a useful measure. This is LS strain by spectral tracking to the left, to the echo. To the right, you see the typical trace with the reservoir strain and the pump strain. And this paper is not yet published, but it's submitted today or tomorrow, actually. And we could show that, first of all, the reservoir strain and the pump strain tells about the same story. That's one message. Furthermore, if you measure either reservoir strain or pump strain, if there are low values, like in this illustration with all the patients here, you see LA reservoir strain when that is low, when it's less than 18%, it's most of the time a high filling pressure. When the LA strain is high, more than 18, most of the time it's a normal filling pressure. But importantly, it's not perfect. It's not at all perfect, but it's pretty good. Now, the issue with LS strain, reservoir strain, and pump strain, they are useful in our hands in this study, but they work best in patients with HFrEF. With HFpEF, they're giving some information, but not as good as with the HFrEF. So LS strain can be used to replace a missing variable, like the peak tricuspid regurg velocity, and can then get the useful additional variable to assess filling pressure. Reservoir strain in the left atrium is determined by filling pressure, upper left panel, but even more so, the reservoir strain is determined by the left ventricular systolic function, the GLS, because the LV stretches the left atrium and therefore contributes to the LA reservoir function. Now, if I may conclude, it's that early diastolic stiffness, it reflects active relaxation, can be assessed by the E prime. The mid and late diastolic stiffness reflects the passive diastolic properties and is modified by remodeling. The EDSL time is useful, and well, I shall repeat this stuff here. That's the two markers, E prime and E deceleration time, are good measures. Not perfect, but useful measures. Now, furthermore, an elevated LV filling pressure most of the time reflects increased LV stiffness and can be assessed successfully in most of the patients by Doppler and echo. And furthermore, the little bit novel news now is that LS strain, which has been around for about 10 years, we have shown now that it will increase feasibility of assessing filter pressure by echo. And finally, we should remember that our patients undergoing TAVR, they may have a problem with the diastolic stiffness, which should be taken into account when you assess their function and give them medication. So thank you so much for your attention.
Dr. Smith for that excellent and informative presentation.
Bueno, ahí están, jóvenes.
Sí, doctor.
¿Me escuchan? Bueno, nada más quiero que
Sí, doctor.
hagamos un último repaso sobre esto que comenta el doctor de Oslo. Cómo divide el periodo de llenado diastólico temprano, medio y tardío, ¿no? Y donde la rigidez se lo pueden atribuir a diferentes componentes, ¿no? Como relajación activa y las propiedades elásticas pasivas, ¿sí? Y se modifica por el remodelado. Cómo utilizar la E' utilizando la E' es un parámetro de la relajación del ventrículo izquierdo, ¿sí? Y una de las cosas que no hacemos mucho, pero es que tanto es medir la desaceleración cuando tenemos la onda E, ¿sí? Luego la onda A, el tiempo de aceleración de la onda E, ¿sí? Nos da otra parte de estudio de la función diastólica, ¿verdad? Y otra parte importante que como que no tenemos mucho en cuenta es esto último de acá abajo, ¿no? Sí, si bien el strain de la aurícula izquierda se estará posicionando próximamente sobre otro parámetro de función diastólica y evaluar las presiones de llenado del ventrículo izquierdo, bueno, pues si no tenemos el strain disponible en todos lados, pues menos el de la aurícula izquierda. En realidad nada más es cuestión de engañar un poco a las máquinas y poderlo hacer. Pero otra parte importante es esto, ¿no? O sea, una de las cosas que ustedes después empezarán a ver y empezaremos a ver cada vez más es que el paciente post-TAVI, no lo podemos dejar nada más así, ¿no? O sea, tenemos que tener un buen control de sus cifras de presión arterial, un buen estado de volemia, de volumen, sí, un buen control de cifras de glucosa, ok. Una parte muy importante que mencionó el primer ponente es la rigidez arterial, ¿no? Entonces, y el ejercicio ha demostrado que esa rigidez arterial lo pudiera modificar hacia un parámetro mejor, ¿ok? Entonces, ahí es donde entran programas de rehabilitación física, ejercicio moderado, ¿sí? Siempre tratando de mejorar ese acoplamiento entre el ventrículo y el sistema arterial, ¿ok? ¿Algún comentario? Jóvenes, Maitán.
Pues también recordar un poco lo que mencionaba al principio, tener en cuenta los diferentes mecanismos que pueden llevarnos a una insuficiencia cardíaca con fracción de eyección preservada, que son un gran número, y también tener en cuenta pues la situación clínica del paciente, o sea, tener un constante, una constante relación médico-paciente y tratar de enfatizar un adecuado apego. Si bien no tenemos todos estos métodos para medir disfunción diastólica, pero sí tenerlos en contexto porque en un futuro van a ser más importantes cada vez y va en crecimiento el diagnóstico de insuficiencia cardíaca con fracción de eyección preservada.
Sí, vieron cómo se divide la división de fenotipos, ¿no?
Sí.
Esos 3 fenotipos que hacen hincapié y que después el doctor de Noruega hace hincapié en esos fenotipos y presenta ejemplos estructurales, ¿no? Y otra de las cosas muy
Sí.
importantes, ¿saben? Como si de lo que dices de que si algo en el 2020 se le puede dar al strain del ventrículo izquierdo es el diagnóstico de amiloidosis, ¿no?
Exacto.
Sí, Ricardo.
Sí, doctor, aquí estoy. Pero bueno, estoy viendo que realmente de los parámetros que más nos ayudan, o los más comunes, pues sí tenemos la oportunidad de medirlos.
Sí, claro.
Todos, y con toda la información que ya nos dieron, sí es una muy, muy buena herramienta diagnóstica que está al alcance. Nada más, pues como en todo, ¿no? Ponerlos en práctica y darles el significado en el contexto del por qué estamos haciendo el estudio.
Sí. Exactamente. Ok. ¿Algo más? Eric, Miguel.
Pues algo más, pues realmente, pues no es tan, me pareció bastante bien la revisión, como desde el inicio, como bien mencionan los fenotipos y mencionan cuáles son los mecanismos fisiopatológicos, ¿no? En el caso de la tensión arterial, como el aumento de la actividad simpática, la activación del sistema renina-angiotensina-aldosterona, consecuentemente se asocia al aumento de las presiones de llenado. Y luego las gráficas ahí que mostraron también de los estudios, como pues lo que caracteriza a la falla diastólica es esto mismo, el aumento de las presiones de llenado, incluso en comparación con aquellos pacientes con insuficiencia cardíaca con fracción de eyección disminuida. Lo que ya habían mencionado de la amiloidosis, los patrones ahí restrictivos y cómo el strain lleva al diagnóstico los mismos. Luego las otras herramientas como el strain de la aurícula izquierda y demás, me pareció bastante bien y bastante pues para actualizarnos en esos aspectos.
Pues igual,
Ok.
pues me pareció interesante, y realmente muchas cosas que hemos revisado en clase y que vimos, yo creo que en las clases de falla cardíaca muchas se tocaban acá, y pues también lo que mencionaba de vigilar a los pacientes post-TAVI, porque pues obviamente pues sí pueden igual cambiar las presiones a nivel ventricular con consecuente al recambio valvular, y pues sí ameritan un seguimiento más estrecho.
Sí. Ok. Bueno. Muy bien, jóvenes. Pues si no hay nada más, entonces mañana a las 7 clase. Le toca
A Miguel García.
Alicia, doctor.
Miguel. Bueno. Mitral y aórtica, ¿verdad? Y cateterismo en esas patologías. Bueno.
Así es.
Ok. Sale, jóvenes. Gracias.
Gracias,
Muy
doctor.
bien. Gracias, doctor.
Pero
Bye.
Gracias. Bye.
Bye.